This conference will now be recorded.
Hi, everyone. This is Len Sierra for AnCan's video chat session for high-risk recurrent and advanced prostate cancer. The date is February 28, 2023. And we're going to start off by acknowledging our sponsors, and Peter Kafka will call them out for us.
Yes, Bayer, Pfizer, Myovant, Janssen, Myriad, and a general sponsor is Foundation Medicine.
And we're soon to add Telix. They should be there, but they're not there yet.
Okay. Thank you. Someone needs to make me a organizer. That's maybe why I couldn't see the posting.
I'll work on that.
But let's start with Peter Kafka, who told me that he's needs to be gotten to quickly. I guess you have another assignment or appointment.
Yes. So I'll make this short as possible. I'm not going to go into my whole history, but I think most of you guys know that I'm a strange one. I'm not doing the same thing most of you are, or any of you are. I don't think. I'm a mismatch repair gene guy, Lynch syndrome, that seems to be driving my cancer, that particular mutation. And that has led me, after all kinds of other treatments, led me now to Keytruda. And I just did my 6th infusion last week. No side effects this time to date. However, I'm in a study of one, my own study. It's NCT 96708. That's my zip code. So you won't find it in the clinical trial thing, because there aren't many people doing what I'm doing. There are many people on Keytruda, but there aren't many people that are doing it with prostate cancer that have the genetic mutation profile that I seem to have. At least not many I've discovered. And as a result, my doctors don't have anybody like me. And we're trying to figure out what to do. So I'm fine-tuning my my Keytruda infusions. So originally it was set up for 3 weeks, and I was starting to get some intestinal side effects from it. But my PSA was dropping, so we decided let's try dropping down to 6 weeks. So we tried dropping down to 6 weeks, and the last blood test I had, my PSA went from 0.34, which is very low for right now, and up to 0.68. It doubled. So I went back to my my local oncologist. I went to the PA a couple weeks ago, and the first thing she said was, "Well, the doctor and I think you should go back on Lupron." And I held up and I said, "No, slow down here. I don't agree with you. I don't think we should go on Lupron again. I think we should stick with Keytruda and see where it goes. And I think we should adjust the schedule. Instead of 6 weeks, let's try 4 weeks." And they trust me. And she said, "Okay, good enough. Let's try 4 weeks and we'll see where it is." So as I said, I'm in a study of one. And fortunately, I have doctors that aren't pushy and demanding. And I right away wrote to Dr. Antanarakis, one of my other medical oncologists up in Minneapolis, and told him what was going on. And he said he agreed right away and wrote me back and said, "Good move. Don't go back on Lupron. And I think you're doing the wise thing going to 4 weeks." So, and I'm going to meet with Dr. Schultz next week on the 9th. I'm going to fly to California for the mid-year PCRI conference and meet with Schultz and have a face-to-face. I haven't sat across the desk from him with him for 3 years now, but update him and get his take on it, and I'll have another blood test that day take with me, and I'll kind of know more information. So I just wanted to let you know what's going on and how I'm managing my treatment and my disease. And I'm hopeful and optimistic, and I don't know where it's going, but all I can do is look up. So that's it for me.
That's great. Thanks, Peter. You're the paradigm of mutual decision making with your physician, informed mutual decision making. And we'll be watching your case with a lot of interest.
So I have a couple of questions for you, Peter. What is your PSA right now?
As of 2 weeks ago, it was 0.68. And
Okay, so
right.
it's been pretty steady then since the beginning of the year, right?
Yes, when I came back to Maui, it dropped from 7.5 down to 2, and then it's been dropping now for a while. Yeah, since the beginning of the year, it's been under 1.
So, because I have here a note that after your fourth treatment back in December, you were 0.67. So it seems like it's it's hanging in there. And how many Keytrudas have you done in total now?
6 now.
And what is it? I mean, we just saw today that Merck is calling a halt on the enzalutamide Keytruda trial, and we heard from what's his name at Yale, Petrelak,
Yeah.
that at GU ASCO that there was nothing seemed to work for docetaxel and Keytruda for prostate cancer. The problem is that whenever they report this, they don't report how many of the people are MSI high and how many of the people might have a mutation. So what is it that makes you of an N equals 1? What is the difference in what you're doing?
Well, as I said, I don't think it's very common for mismatch repair gene mutations to be driving prostate cancer. It's kind of rare. I think that's my understanding. They put a lot of people on prostate cancer on Keytruda, and I remember asking Dr. Antanarakis when I was in Minneapolis last summer. I said, "What are the success results?" And he said to me, "Well, about 80% of patients it doesn't work for." And I was just starting it then. I said, "Really?" And then he said, "But in your situation, you've got an 80% chance of success rather than failure."
Right.
Because of the mismatch repair gene. Yeah.
Well, it's because you're MSI high. I don't know if that's attributable to the mismatch repair gene, but the MSI high is the indicator, and Keytruda has what's called a basket approval. So it doesn't matter what the cancer is. If you're MSI high and you've got a high tumor burden, then you're eligible for Keytruda, whatever your cancer is. So,
right.
I don't know. I mean, what is the relationship, Len or Herb? What's the relationship between MSI high and mismatch repair? Is there one?
Yeah. The mismatch repair is definitely correlated with microsatellite instability.
Mm-hmm.
And Peter also has the Lynch syndrome gene, one of them,
right,
which also, I believe, predisposes to MSI high.
Right.
What about PD1 or PDL1, Peter? Do you have those markers?
I think so. I think I have the PDL1. I can't have to pull it up. I'm pretty sure.
So, I think that my observation, for what it's worth, is that if a man has these markers if he's MSI high, and we've got other people, I don't know if there's anybody on today, but I know we've had other people who are MSI high with prostate cancer, then it is definitely worthwhile to look at pembrolizumab. It could make sense to look at pembrolizumab. And that's one of the issues that I have with these two trials that have reported. That they say, oh, the trials failed. Maybe they did fail, but was there any success for people who had the right markers? And were there any people with the right markers in the trail? There's a couple of people with hands up, Len. Can you see the hands up,
let's
Len?
go to Steve Schuler had his hand up first, and then we'll go to Ben. Go ahead, Steve.
Yeah, I guess I'll wait until you're done talking about the MSI aspect. But when you said you were not going, that Lupron was not a good option, was that simply that you expected that was not going to have any effect because it was driven by the mismatch repair? And my interest is because I've just started on Lupron 3 weeks ago.
No, I've been on and off Lupron for 8 years. I know the effects of it, but in my estimation, the Keytruda is working, and why cloud the issue? I mean, I think this doctor was just grabbing something off the shelf because he saw that my PSA went up, a little bit, and maybe we thought, well, we should bring the PSA down. I mean, that's not good reasoning for me to go back on Lupron.
Okay.
Yeah.
Thank you.
So, Peter, this is Al. So you're not on anything else other than the Keytruda right now?
Only the Keytruda. I stopped Lupron over a year and a half ago, and I stopped darolutamide 6 months ago.
And what's your testosterone now?
It's been hovering around 70.
Around 70.
Because I've been on and off ADT for so many years that I don't think it's going to come back over 100. Maybe it surprised me, but I don't think it will.
So you've dropped your PSA from 7 something to under 1, and with nothing else, and
only on
only
Keytruda.
a few side effects. So
only on Keytruda.
That's wonderful. Congratulations.
Yeah.
Peter, this is Dennis. My wife has just started her chemo for a triple negative breast cancer, and that's one of the things that she's taken is Keytruda with 2 other chemo agents. But my instinct was to dig in and see what I could learn about it. And you mentioned the PDL1, and they say it has to be a PDL1 score of 10. Now hers came back as a 12, so that was the sign to go ahead with it. Because you don't get very good results if your PDL1 score is less than 10.
Right. And does she carry any mutations? What mutations is she carrying? Is she MSI high, Dennis?
No, we don't have those yet. We're still waiting on the approval for the genetic testing.
Yeah, it's used a lot for other cancers for sure. But so one more final thing. This is an interesting fact too. So I sat in on a very small group of us that was a lecture by Dr. Sartor, who's moving to Mayo shortly, if he hasn't already, who was at Tulane down in New Orleans. And he's a medical oncologist, prostate guy, who has a great interest in genetic mutations. And he had a chart in this talk that really caught my attention. He was tracking the when in your age certain genetic mutation would kick in and drive the prostate cancer. And most of them were like BRCA1, BRCA2 were a pretty big range. But when it came to the particular gene mutation I have, which is MSH6, all of a sudden, at the age of 66, it shot straight up on the chart, on the bar graph. like it was nothing before that, and all of a sudden it shot all the way up to the top. And I questioned him. I said, "What's with that?" And he said, "I don't understand it either, but it seems like if you've got this particular gene mutation and it drives your prostate cancer, it doesn't kick in till you're 66." And I said, "Bingo! That's when I was diagnosed." And so that's a head scratcher. It's amazing some of the things that that they've got, on their radar, and what it all means, I don't know.
Ben, you had your hand up before. There are often pearls of wisdom that come out of that icon. What was on your mind? Is Ben? I don't even see Ben. Oh, there he is. No, we can't hear you. Still can't hear you. This is what happened last week.
Yeah. Time for some new equipment, Ben.
Yeah. We did fine. Yes.
I had a microphone issue and I reloaded the page to give it permission, so it might be reloading. Could help you.
Oh yeah. Try and reload and let us know. But we did fine with Ben and I were on the on this yesterday, and we did just fine. So anyway, I don't know.
I think I heard Ben earlier today.
Yeah, we did.
Well, anyway, while we're waiting on Ben's pearls of wisdom there, let's go to Ed Claudis. Go ahead, Ed.
Okay. Do you hear me?
Yes.
All right. So I'll try and run through this quickly, but say roughly March of 2022, I started getting docetaxel treatments, and I turned out and that did nothing for me. I was then on the attempt to get on to Pluvicto, and I passed my Pluvicto test. That I had tons of PSMA, and so I was very excited for that. I then went to Germany and did 2 treatments there because it wasn't quite legal in the US yet. And then after that, I did 2 treatments at the University of Florida. And after that, I did 1 treatment at the University of Kentucky. And when you looked at my PSA scores, they were just a rocket ship at a 45-degree angle, going up. And so I now have had about 3 or 4 treatments of cabazitaxel, and that didn't do a whole lot for me. And so, in all honesty, right now, guys, I need somewhere to go. And I feel like I'm back where I was a year or 2 ago. But what can I say? They just finished telling me today that they essentially got nothing for me now. My PSA used to be, just for jollies, guys, used to be under 10. It would kind of hang out under 10. And that was, but I knew that was, but I would scan out for enough tumors to light up New York City. And I'm trying, so are there any, I hope I've covered as much as I can.
What's your PSA, Ed? You haven't told us.
Oh, like 150.
Okay. And are you certain? I mean, I know you've had 5 treatments, and I know it sounds like a silly question, but are you certain you're PSMA avid? Did you light up on a PSMA scan?
I did, yes.
Okay.
I lit up beautifully.
Okay.
So then you're Pluvicto eligible, right? Because you've had your chemo and you've had.
Right. No, I was very Pluvicto eligible. I spent $50,000 going to Germany to, start taking treatments in Germany before they were legal in the U.S. And, but yeah, you take all 5 treatments and it's essentially a straight line at a 45-degree angle. So
So in other words, you're saying the Pluvicto didn't do anything for you.
That was my interpretation and my oncologist's interpretation. That's why we only went to 5 treatments and not 6.
Who is your lead oncologist? Is it still this fellow at Kentucky?
No, he left and went to Ohio State. It's now some lady named Pandy, and so that's who that is. I do not have the requisite rock star of a genitourinary oncologist.
Okay. So I'm sorry, who did you say it is now? Somebody called, is that Handy at Johns Hopkins?
Pandy.
Oh,
And
Pandy.
no, she's in Lexington, Kentucky.
Okay.
She's not a special doctor.
I'll go back to Len, but I think at the time, and I know some people, I heard about today about a guy who didn't like this information and this advice and never came back to us. I know exactly who he is, but we feel very strongly you have to have a really good GU med onc. And at this point, if they can't figure out what to do, if it were me, I'd be getting my ass over to one of the best GU med oncs that's out there. Len?
Well, I did not mention that last December I did a trip down to MD Anderson, and in essence they told me the exact same thing of we got cabazitaxel for you, and that's what we got. I think his name is Korn.
Korn, right.
Yeah.
Well, you can try Dr. Eleni Efstathiou at, I think it's Houston Methodist.
Dr. Eleni. Okay, I live in Kentucky, just to let you know.
What about BAT?
What is BAT?
Bipolar androgen therapy.
Good talk.
I am a totally uneducated person when it comes to that set of words.
Well, we've had people try it. We've seen it's being spread. It started at Hopkins as a novel therapy where they load you up with massive doses of androgen, alternatively with enzalutamide, and some people have responded nicely. Now, what about your genetics, Ed?
They came back nothing for nothing.
No P53 mutation, no mutations at all.
I couldn't get a mutation out of my genes for nothing.
So you're saying that who did they send the report to, Ed?
The genetics report,
Yeah, I mean, there are two types of genetic tests. Did you do both of them? Did you do a germline test and a somatic test?
I'm pretty sure I did. It's been a good long while, because at the time I remember you asking me that, and I was like, no, no. And then I found out that I did do it. I think I did both types.
Well, if it's a long while since you've done the somatic test, your medical oncologist should be calling for another one, because it changes over time, and especially after all the treatment that you've had and the cabazitaxel now and everything else. So one thing is to definitely rerun your somatic test, and you may, with the level of your PSA, you can probably just do that as a blood test, which would make it much easier for you. There's no reason why, and you can, it's covered by Medicare. You can order it, get it done right away. And that's something I do.
Rerun a somatic gene test. Is that
somatic, what you want to do is you want a somatic genomic analysis. I mean, just tell your doc, don't ask her, tell her that you want an updated somatic sequencing. Okay. Now, the second thing is that if it were me, I would be getting my ass over to a strong lead doc. I mean, go back to Dr. Korn at this point in time and tell him it's not working, and see what trials he's got. Consider Dr. Efstathiou, who's right next door at Houston Methodist. If you weren't happy with Dr. Korn, think about Dr. George or Dr. Armstrong. I prefer Dr. George at Duke. That he's in your backyard. Try Dr. Szmulewitz at University of Chicago. He's on top of all of this. But these are the type of docs that I mean,
you're right.
These are the type of docs that are going to come up with a solution. They're the ones that are going to say to you, "What about BAT?" That's why we want you at somebody who knows what's going on, because they know that BAT can be used. And Dr. Korn is using BAT with one of his patients right now that we're aware of.
Okay. Well, does it help that I have a history of having been there?
Probably, but if you weren't happy, and it sounds like you weren't happy, you have to decide if you want to go back.
Yeah.
Just because you have a history, you're the boss. If you feel that they didn't give you the time of day, then there's plenty of other strong, good docs that we can navigate you to. They know us. Dr. George knows us very well. Dr. Efstathiou knows us very well. Dr. Szmulewitz knows us very well. Dr. Korn knows us well. But rather than sitting there and saying, well, I don't know what to do next, part of it is we can guide you to the doctors who will tell you what to do next.
Sure.
And Dr. Pandy is probably not one of those doctors.
No, I think you're right. And I've had her only since January, because this guy just quit. But what was there was Dr. George at Duke, and there was a guy in Chicago.
Szmulewitz. Somebody will put it in somebody will stick that in the chat window for you, or I'll do it in a second. So, I think that this is where you have to go. You have to let them, and when you call up, you say, look, I'm coming from AnCan. My PSA is 150. I've done five sessions of Pluvicto, and I'm not getting anywhere with cabazitaxel. I need an appointment, and quickly. Because if you don't say that, they'll say, oh, yeah, you can come in 3 months. You don't want that.
Right. So there's Dr. George at Duke, and they're actually about equidistant, but that's not a big deal. I went to Germany. I mean, what the hell? Okay. Okay. So there's Dr. George and Dr. Szmulewitz, and
So,
I can say that,
we can give you some advice, but we want you to act on it. I mean, and Herb's suggestion of BAT was great. Anybody else got any other suggestions they'd like to make to Ed?
I was
Yes,
just
go
wondering
ahead,
where.
Yeah,
Ward.
yeah. I just wanted
pardon me?
to add for Ed that yeah, we are aware of one guy who's participates in AnCan, who's being treated, getting the bat treatment through Dr. Korn, and I know that Dr. Korn has been very supportive and helpful in facilitating that treatment. So unless you just didn't connect with Dr. Korn, he's my primary GU med onc, and I like him a great deal. I think he's done very well by me, but unless you guys just didn't connect for some reason, I think you should at least consider running that by him potentially before you jump to some other different GU med onc. Those are my thoughts.
Now, my family is from mostly Fairfax, Virginia area, and my dad went to Johns Hopkins, and I heard Dr. Eleni and bipolar androgen therapy.
Yes. I mean, that was pioneered by Sam Denmead at Hopkins, and he has other guys working with him. Mark Markowski is working on that area and publishing as well. So you could go directly to Hopkins.
Yeah.
And Tanarakis up in Minneapolis is also well versed in bat. He worked with Denmead. He still does it.
I think it's expanding.
Okay.
Herb, is there a clinical trial status on BAT therapy?
Well, they've got, I think it's beyond that because nobody wants to pay for the testosterone.
Right.
I mean, it's sort of like, they're going to do a clinical trial, but the problem is there's no money in it.
Right.
The testosterone is pretty cheap.
Right.
Yeah.
It's the enzalutamide that costs money.
Okay, but that would be covered by Medicare, I would imagine.
Probably.
So,
Yes.
I don't think the testosterone is covered by Medicare.
It's so cheap, though.
But
Right.
it's cheap. Okay.
Yeah. I mean, guys, I think we've got to move along,
Yeah.
and we can't really educate you about each of these different types of treatments. But what we can do is tell you there are things out there. There are also some other interesting trials that are out there and new stuff coming in. And for people that are not responding to Pluvicto, that is a head scratcher, and a lot of these oncologists are eager to work with those people because they have their own ideas of what could come after it. But we've just got to get you to one of these doctors and come back in next week. Tell us how you're doing. If you need help from us to get you to any of these doctors, we've got men with all of them, and we can open the door either through ourselves or we can open the door through one of their patients to help you out.
That is wonderful, and I thank you very much. I'll let you move on with.
But one last word: don't wait. Don't wait anymore. You need to see a GU med onc ASAP. And if you have an onc local that says I can't do anything for you, you got to get out of that. You got to say I'm through with you.
Well, that's kind of hence the attendance at this call, but yes. No, thank you all very much.
All right, Ed, good luck. Steve Schuler, I want to check in with you. I think I asked you if you wanted time, but are you new with us?
I've attended one before. Um,
Did you give your
I
history?
I think I did. I think what's changed is I've decided to go on an adjuvant approach. My prostatectomy showed 3 positive lymph nodes out of the 13, and some other high risk features. And I've decided to go with adjuvant radiation therapy and ADT. So that's all kicking off right now. And I don't have a specific purpose in being here today. I just kind of to listen in, really.
Okay. You're
Yeah,
welcome to
I
do that.
think, yeah, you're very welcome. I think, Steve, that you may have been in Peter's group. I don't know if you've been in this advanced recurrent group before. I know I don't have any notes on you, which is rare. So, but come on back and, we'll help you any way that we can.
Sure, I haven't had any problems with the ADT yet, but like I said, it's just been 3 weeks, so I'm not sure I would expect it yet. But
Well, if you have problems, this is a good place to solve them because most of the guys on this call at one time or another have been through every one of the symptoms that you could possibly imagine from ADT. So somebody has a T-shirt if there's something that you want to run past them. Are you on our mailing list? Did you get a reminder for this meeting?
I did, yes.
Okay.
All right, Norm Pollock, you said you had a quick update for us.
Yeah, I just had blood work. All came out pretty nice. PSA below 0.1. They didn't do the high sensitivity, but I was having the cramps so bad, and I got the pickle juice, and I found this. It's called Salt Wrap is the company. It's called Mag R&R. Take 2 to 3 pills every night, and I haven't had any leg cramps since. So I'll put it in the chat for anybody who's having cramps. It seemed to work, and then they just sent me a little card with 22% off. I'll put that in there too, but seems to work for me. I don't know if it'll work for everybody, but
How long has it been working for you, Norm?
2 weeks. I haven't had a single cramp in 2 weeks. At
Okay,
night.
that's pretty good.
Couple on my hands during the day, but my leg cramps are gone, and oh geez, those were nasty. I was
And nothing
not
else? You
happy
didn't
with
do
those
anything
at all.
else to change your?
Yeah, and it seems to be working. I'm happy. I can halfway sleep other than the hot flashes. So
Okay.
I'll put it in the chat in case anybody else needs it.
You know, this is John. I often hear stories about magnesium helping with leg cramps, and when you measure people's magnesium levels, they're not low, and yet I hear over and over again stories like that. So it always is worth trying. It sounds like.
Yeah, this
And you
is more
always,
than this is more than magnesium.
Oh, it is. Oh, okay.
Yeah. Take a look at it if you want.
And then after you've been fine for a couple of months, you could try
2 weeks.
getting rid
2
of it and
weeks.
see what happens.
But it was really, I mean, they were lasting 10, 15 minutes, both legs, the whole leg. I was like, oh man, I couldn't. Oh. My wife wasn't sleeping either. That's all I got.
Okay, thanks, Norm. Let's see. I wanted to go to Jim Ward, and then Jim Jeffries. Go ahead, Jim Ward.
Hey there. I don't need any time tonight, Len. Thank you.
Oh, but you did. Okay. Jim Jeffries.
Before we go to Jim Jeffries, can I just check in that no one had any questions on that cramp? Because I know Dennis Correa is our usual go-to person when it comes to cramp meds, and I just wanted to make sure nobody had any questions for Norm Pollock on this salt wrap.
Yeah, Norm, is that you take that as a preventative, or do you take it once you get the cramps?
I would take it. They want you to take it as a preventive. I take it about an hour before I go to bed.
Okay, good.
Yeah.
Dennis, you take the, I forget what it's called, Thor something.
TheraWorks, WRX.
You
yeah.
take that only after you got the cramp, is that right?
No, I could take it if I've had a very active day, exercise-wise, golfing, whatever. A lot of time on my feet. I'll do it preventatively at night, or sometimes even before. If I'm on a long drive, sometimes I'll get a cramp in my leg. And I'm going to know that I'm going to do that. I'll put it on before I start the drive, and it works that way to prevent it. But I've woken up sometimes in the middle of the night with that wicked cramp, and you're trying to stretch it out or do whatever, and you just can't get rid of it. It hurts. And I get the TheraWorks on there within 30 seconds. It's gone.
Yeah, TheraWorks worked pretty good for me.
Okay. Jim Jeffries, go ahead.
Hi guys. I'm fortunate. Well, I was on a drug holiday for a year, and I guess it's time to go back. So my PSA started doubling in January, and it's always been historically low. So the drug that's recommended is Erleada. Erleada. 4 pills a day, and to go back on Eligard. Now, has anyone had experience with Erleada?
Anybody? I can tell you it's a kissing cousin of enzalutamide. They're very similar structurally. The side effects are almost identical. There's considerable fatigue for most guys, not necessarily all. There's a slight risk of seizures, just like with enzalutamide.
Okay.
Anybody actually on apalutamide or Erleada, same drug?
Right. It is apalutamide. So why would they pick it? In this day and age, why wouldn't we go with darolutamide?
Yeah, good question.
Yeah. I think that if you ask the guys in this room right now, most of them, if they had a choice, would be looking at Orgovyx plus darolutamide, if they could get it. That would be the optimum. And there are a few guys on that combination. The Orgovyx is the pill form of the Eligard, and the darolutamide or Nubeqa is a better alternative to apalutamide or Erleada because it doesn't cross the brain barrier. And so you get a lot less fatigue and you get improved cognition with it. And if you're with a strong and a good GU medical oncologist, they can usually push and get it for you. If you're not, and it's just a local person, they don't understand it and they're not going to push for it. That's been our experience. Len, you wanted to say something?
Well, no, I was just clearing my throat. But yeah, I've been on darolutamide, Jim. I've also been on abiraterone. I've never been on enzalutamide or apalutamide. But darolutamide, for me, was far, far less fatiguing than abiraterone.
This is
And
Alan. Is it required to be castrate resistant in order to get darolutamide?
used
Not
to be the
anymore.
case.
What was
Yeah,
that? Not anymore?
yeah. I think that, well, first of all, it was approved as part of a triplet therapy for hormone sensitive metastatic prostate cancer, part of a triplet therapy. But, a lot of doctors are prescribing it to guys who don't really qualify for it. So they just find a way. I don't know how they do it, but as in my case, I wasn't technically eligible for it, but my doctor got it for me. I think that maybe it depends somewhat on the sway of the oncologist with the insurance company. I'm not sure.
In terms of
But
Medicare, are they more accommodating in terms of allowing that, or are they more rigid?
well, I was on Medicare and I got it.
Okay.
It's not Medicare. It's whoever you're carrying your
Right, the
supplementary with.
drug company.
Secondary.
Yeah, yeah. No, that's fair. Yep.
No, not the drug company. Your payer, whoever
Right.
your payer is. That's
Yeah. Yeah,
where it's going to be the issue.
yeah, the Part D insurer. Yes.
So,
Yeah.
Jim, you can try talking to your doctor and say, hey, I've heard that darolutamide produces less fatigue. Can you switch me to that? And
Okay.
got nothing to lose, right?
Okay. I did. I had a second opinion, and I talked with Dr. Geinesman at Fox Chase and my oncologist, and they both concurred that this is probably the appropriate action now to get on the Eligard and the Erleada. So I'm basically, I guess, ready to start.
Jim, maybe you understand. Eligard and Erleada can be substituted with darolutamide and Orgovix, and it would be likely better for you.
Okay. Oh.
It's unlikely that a doc like Gainesman is you're going to go in and you'll say, well, my local doc wants to give me Erleada and Eligard. And Gainesman will say, yeah, that's fine, that'll work. Now, if you turned around and said and if you asked him this question, and maybe you did, but if you asked him what would be the best alternative of those two, my guess is he'd probably say Orgovix and darolutamide. So he's not going to disagree that it's a bad thing, but if you don't ask him the question, he's not necessarily going to contradict. Somebody like some of the other docs who are more aggressive that we work with would do that. I mean, Julian's not on today, but oh yes, he is. Julian is here right now. Julian went to Dr. E and she took him off of those similar drugs and she put him on Orgovix and darolutamide. And he wasn't in a very different situation to you, right, Julian?
Yes, I mean she saw good results with me, and after about a total of a year or so, part of that being on Orgovix and Nubeqa, darolutamide, she took me off.
Right.
I was good to go.
Took you off completely with no alternative?
I don't need it. She told me I didn't need it anymore.
Okay. And your PSA stayed stable?
Yes.
And how long were you on it for?
For about 9 months.
9 months? Okay.
And then I was on Lupron and Abby before that.
Okay.
Those two made me gain about 20 pounds. She said she didn't like that. And it gave me a bunch of brain fog. So she said, no, we need to change. And she took control.
We sound a bit like a broken record, but there's good reason for it. Don't just get a second opinion from these docs. Move your care. You're treated differently when you move your care. Everybody nobody on this forum right now should have a general medical oncologist as your quarterback doctor. categorically. Nobody. And if any of you do, don't be surprised when you say to us this, that, and the other, and we say, who's your quarterback? And you say, well, it's a general, and we say, well, drop him. We tried to convince Ecplaudis about this a long time ago. It is so important because the field is moving so quickly and the local guys cannot keep up with it. And they don't understand the difference between apalutamide and darolutamide because they're not reading the trials. Just recently at GU ASCO, one of my brains trust hopefully can put a link in the chat window for you. Dr. George, one of our favorites at Duke, reported a trial comparing darolutamide, apalutamide, and enzalutamide. And the first time that we've really seen meaningful straight ahead comparisons. God knows how he did it, but he did it. And darolutamide came out streets ahead. Now, your guy probably doesn't know anything about that trial. We've been saying this forever and a day.
Mm.
But, you know, it's not good enough. Ben says, wasn't that trial for non-metastatic castrate resistant? It may have been. It may
I
have
don't
been
think
for
it matters, really.
Yeah, but that's right. I'm not sure it matters because we know about the side effects. Are the side effects different if you're castrate resistant or you're not castrate resistant? But you're on Lupron. You're on a no.
No.
You know, and this is why we want you guys not just to get second opinions. We want you to have these docs as your primary care doctors. I mean, you can ask anybody anybody, any icon on here, ask them what sort of doctor should be your main doctor. And they'll tell you, they may not have it, but they know, Jim, get your care out of this guy. Move it to Gainesman or move it to Narayan. Narayan's another great alternative at UPenn. He's a great guy. Those are the docs that we want our AnCan participants to be seeing.
Okay.
And can I ask? I want to ask a question. I want to go back. I want to step on Jim, but I want to go back to Steve Schuler, because didn't Steve say he was just on Lupron and nothing else?
That's correct.
Do we need to twist Steve's arm to get Orgovyx and
I mean
darolutamide?
that's not what. Who's running your care, Steve?
Dr. Yu at Fred Hutch.
Well,
we don't really know Steve's history, though it might be appropriate, right?
I mean,
we don't really know.
Evan Yu is a good doctor. Evan Yu's on top of his game.
He is a very good doctor, but I mean, I just listened to Neil Shaw and Matthew Smith this morning, and they don't think anybody should be on anything other than doublet therapy now. Everybody should be on doublet therapy, and it shouldn't be sequential. And this is what we're seeing. So I would go back to Dr. Yu and say, Dr. Yu, is there a reason why you just have me on an ADT drug and not on doublet therapy? I mean, this isn't coming from us. We're not docs. We can't give you medical advice, but this is what we're hearing from the docs. At least doublet therapy at a minimum.
What made me think of it was that he said he didn't have any symptoms yet, and man, I had with the darolutamide and the Orgovyx. I mean, I had symptoms within a week. I had hot flashes. I mean, and within 3 weeks, my testosterone went from 745 to less than 3. So it works. I mean, it does exactly what it's supposed to. And
Different drug. He will have symptoms given some time. I predict.
Yeah.
Oh yeah.
I mean, the Orgovyx.
Yours drops testosterone really fast.
Yeah.
Right. The Orgovyx. But Steve, send Dr. And he is a really good doctor. We all respect him, but send him a note and say, is there a reason why you don't want me with recurrence, because you appear to have, well, you see, you don't really have recurrence. It's just
I
that
don't
they
have
saw,
recurrence yet. Yeah, I
yeah,
mean,
but they,
Gleason 9, 100, all the cores had
yeah,
cancer, etc. I mean, I had a lot of high risk features, and the lymph nodes is the bad
right.
thing.
And then they saw lymph nodes, and you said you had surgery, right, Steve?
Yeah.
So, they saw it in the surgery. So one of the reasons it could be, Norm, is that they're treating this as a salvage radiation situation, and that Steve's getting the ADT as adjuvant to the radiation, as opposed to a recurrent situation where they would be giving him doublet therapy. So
That's correct. It is an adjuvant to the radiation. They're going to radiate the pelvic bed,
right.
and the other lymph nodes in the area is the main purpose,
Right.
I believe.
So let me ask my brain's trust. Do we have any knowledge of doublet therapy in an adjuvant situation?
Well, they're thinking that's right where I was, but just a year later. I mean, I don't know. So
Well,
I
but
guess it's
that's the difference. That's
biomedical
the
reoccurrence
difference,
as
Norm
opposed to,
Pollock.
I don't know.
I mean, this is like the Jeff Marchi situation last week, where he says, "Well, why am I different? Because you're castrate resistant and you're not hormone sensitive when it comes to the PSMA scan." The year later is clear recurrence, whereas Steve, they're jumping right in, and we seem to think that it doesn't make a difference, even with high risk, if you wait 8 months or you don't wait 8 months. But I got to tell you, if I was in your shoes, I'd probably be jumping in right now. But I think that what would be a really interesting question to Dr. Yu is, on recurrence, doublet therapy would be appropriate. Does he think that there's any reason for you to add a second line anti-androgen to the what are you on, Lupron or Eligard? Lupron.
Lupron. Yeah.
Yeah. Does he think that would be a great question to ask him?
And it would be, which would that be if it was that the Orgovix?
No, that would be in addition to the Lupron.
Oh, which of the? I mean, you've been talking about Orgovix plus darolutamide. Which of those two was the thing that you generally add to the doublet?
The darolutamide is added to the
Okay.
Lupron or the Orgovix. So the Orgovix would replace the Lupron. At this point, it probably doesn't make a difference. You've gotten it. It's gone out for a while. Did he give you bicalutamide first?
No.
Again, hard to understand. He should have given you bicalutamide first. I mean, with all due respect to Dr. Yu, if you would have come on here and said, "I'm not getting bicalutamide first," we would have said, "What about the buffer?" So I don't know.
Yeah, the starting PSA was pretty low. So I mean, it was mainly the other features, just the three lymph nodes plus extra prostatic extension,
right.
multiple spots and positive margins, multiple spots.
That's enough for me. I withdraw my comment about maybe single drug is appropriate, now that I know he's a 9 metastatic.
Yeah,
I was going to say the same thing.
I agree with everybody.
Independent of the salvage radiation, with a Gleason 9 that's outside the capsule, you should definitely be on ADT plus a second line anti-androgen.
Hold on, Len. Len, we can't give medical advice like that. If it were you, that's what you'd do. If it were me, that's what I'd do.
Well, yeah,
you are playing a doctor on TV, by the way, so.
Yeah, I don't mean to be, I'm just saying, as far as I know, that is standard of care. I'm not saying that that's my opinion. I believe that is standard of care. If you have Gleason 9 with extension outside the capsule, you need to be on something. The standard of care would dictate that you be on something more than just Lupron.
Well, Len, the issue is that, and we've seen this before, some of the doctors don't start it until after the radiation is done. So they start them on Lupron, or they start them on the ADT, and then they'll do the radiation, and then at the end of that, then they'll start the second line anti-androgen, which may be Dr. Yu's plan.
I have heard of
Well,
that myself also.
I'll ask now.
Yeah.
I'm glad I joined this meeting today.
Yeah, definitely talk to Dr. Yu about it. He's a smart guy, as Peter said. And let us know.
Yeah.
All right. Where were we? Joel Blanchett, you wanted time tonight?
Yes, thank you. Real quick, wanted to, on my issue with the TP53 on the Tempest report, wanted to thank Ben Nathanson and Herb and Len for some great discussion and explanations over email. And now I know that the TP53 is not driving my prostate cancer. And before then, I thought it was, but that's what Dr. E also saw, and that's why she asked me not to take the FDG PET scan right away. She'll wait on that. So I appreciate the information. You guys did a bang up job to help me out. Thanks.
Okay.
Glad to do it.
Yeah, thank you. It was a learning experience for us too. It was kind of fun.
So let's not keep everybody wondering what it was we learned. Would one of the Brains Trust briefly describe what that little number meant, and so other men can learn from it?
Herb, I'll pass it to
So
you.
the idea is you have normal wild type genes in your cells, and then some of your cells are going to have this mutation. And it depends on what percentage of the gene is mutated, whether it's driving the cancer or not. So in Joel's case, there's a very low percentage of mutated gene for the genes that are mutated. And so those are not likely drivers. So when you say you get above 50% of the gene is mutated, it means every cell will have this mutation in it. But when it's 2 or 9%, few have it. So it's not likely driving the cancer. And that was what we were researching. What does this number mean? What percentage of reads meaning when they do next generation sequencing, what percentage of reads are mutated versus what percentage of reads are normal? And so that's where we sorted it out.
Very good. Thank you, Herb.
Questions, anybody? Okay.
Yeah, I guess just to clarify, not that, but in general, the fact that you have a mutation doesn't necessarily mean any mutation, doesn't necessarily mean it's contributing to the growth or progression of your cancer. Many mutations are completely harmless. All right.
I know when I was under Dr. Antonarakis' care, he was big on the three big ones, RB1, T53, and P10. And I had both the P10 and TP53, even though the Tempest report did not report out on the P10 at all. And I don't understand that. Next time I talk to Dr. E, I will ask her that question. But Foundation One found the P10, but not the Tempest. So I don't know if they don't test for it or if they didn't find it. So that's still a question in my mind. But those are the three big bad genes, mutations that you could have if you have prostate cancer, which means your cancer is more aggressive. And that's why I was concerned about it. But Dr. Yi all of a sudden was not concerned. That's why I started asking the question, what does that 0.9 mean?
Okay,
Herb,
Les.
can I just ask Herb a question? Herb, that
Sure, go ahead.
0.9,
Sure.
is that 0.9? Is that 90%? What is that 0.9?
It was 0.9%.
0.9%. Okay. And
If it
what
was
you're
90,
saying,
if it was 90,
It
it would
wasn't
definitely
90.
be driver.
It wasn't 90%.
Right. But if it was, then it would probably be the driver mutation.
driver.
Right.
So if we see a number over 50 or over 40 or something like that, then we have to start thinking that could be a driver mutation. Is that right?
Potentially.
Okay.
There, I did put a graph that I sent around to you, which sort of showed Kaplan-Meier curves versus percentage, and the lower the percentage, the higher survival.
Okay. Okay.
All right, we'll move on to you, Les Shelderup.
Okay, I missed last week going up to the Mayo Clinic to get the PSMA test scanned again. My PSA was rising at about a rate of doubling every 4 or 5 weeks. It was not real high yet, but it was up to 6.2. The PSMA scan showed significant, like the fecal material had hit the air movement device. It was pretty well smattered all over the torso. So the doctor has advised to go on darolutamide and chemotherapy. And since the chemotherapy was going to be long term, he suggested doing that locally. So he's going to have that taken care of locally and have them direct their darolutamide also. So I'm going to see the doctor locally on Thursday to get all this arranged. And I'm also going to have a video conference with Dr. Russell Zeminski on Friday and discuss it with him. So I'm significantly jumping forward with treatment. And that's about it.
Les, I'm sorry. What was the result of the PSMA scan?
It was significantly increased. Stuff, there's a smattering of cancer all over the torso, really.
Okay.
So it was significantly increased.
Right. Okay. So basically, they've put you on the Arasen's triplet therapy, the docetaxel, right? Darolutamide and an ADT drug. Is that right?
Yes.
Okay. Well, that's good. That seems like the appropriate treatment. Again, not my opinion, the standard of care now. Okay. Thank you for that. Any questions for Les? Okay. Well, let's go to, I think, Mark Valens. You wanted time? No. Okay. Dennis Correa.
Hello, everyone. Just a quick update on my personal situation here. I'm coming up on my anniversary of 7 years since my diagnosis. and initial chemotherapy, Lupron, and second line anti-androgen, some radiation, spot radiation, and I'm still holding at less than 0.1. And I haven't let those prostate snatchers anywhere near me. So I'm dealing, I guess, a lot better with a lot of the side effects that many of you all have had. My complaint about my light cramps, but they're less and less frequent now, and hot flashes are less. So with all that, I'm doing well. So that's I'm celebrating that 7 years, and hope there's at least 7 more behind it. And
so
this is my 20th year since I retired here at Tucson, and loving that also. But right now, I've got my wife just recently got diagnosed, as I mentioned, with triple negative breast cancer, very aggressive. So I'm spending a lot of my time just trying to advocate for her and learn as much as I can about her specific type of breast cancer and the treatments. She has started her chemotherapy with basically what we would call it's a triplet therapy at this point, Keytruda and paclitaxel and carboplatin. And that's going to go for 4 cycles. I forget how many visits that actually is. And then they switch to a different scheme where it's going to be every 21 days instead of every week. But bottom line is she'll be done with her chemo treatments in July, around middle July, and looking forward to the surgery at that point. But so far, we know it's just it's a locally advanced and not considered metastatic at this point. So, but I want to thank everyone because my experience with this group has taught me a lot about how to find information on this stuff and how to also be your own best advocate. Because even though we did a lot of searching on docs and so forth, none of them are really perfect, right? That and communication skills are a big part, and especially with their staff, that's been our biggest issue. And then at the same time, they changed to this navigating care portal system, which frankly is not as good as what they've had in the past. And this is Arizona Oncology. So, and they're just getting that stuff up and running. And because I also use Arizona Oncology here locally for my own treatments, just got my 90-day Lupron and blood work, which is all good. But so both of us are kind of struggling with the new system, trying to get the data that doesn't get put in very quickly. I can imagine how much information, particularly the previous data, how long it's taken them to load that stuff. But other than that, we're doing okay.
Well, thanks, Dennis. I'm glad you're doing well. I'm sorry to hear of your wife's diagnosis, but I don't follow breast cancer, but I see lots of references coming in through my email about advances they're making with triple negative breast cancer. So I think the outlook is probably good for her as well.
Yep.
Any questions for Dennis, guys? We will then go to Dr. Jack.
Hi. I don't know if anybody remembers what I said last week because I had a tech issue. I got cut off. So I'll briefly go over what I said, which I think you may or may not have heard. Is my biopsy came back from the interventional pulmonologist as adenocarcinoma. He was able to get both cytology. He took 3 lymph nodes. 1 turned out adenocarcinoma, the other 2 were negative. He got also, for cytology, he got a core biopsy. I asked my medical oncologist to maybe go ahead and check out the mutational sequencing or whatever. And he said to me, you don't need that. You had foundation studies. I think we don't have to do that at this point. I'm going to check with Sloan Kettering and see whether or not they agree on that. Anybody have any thoughts about that? Herb, anyone? Can't hear. Can't hear you, Herb.
I hear you. Again, Jack, they gave you this, they did the pathology, and it's adenocarcinoma. That's seems to be definitive.
I know. I'm not saying it isn't definitive. I'm talking about the mutations to check if I've changed over 20 years, but I haven't had any treatment. So I don't know if it would change or wouldn't change. So I'm asking you guys because you have
Well, I mean, it can't hurt, right?
Right. So ask for a somatic analysis. I'll ask him
Right.
again.
Let him do some NGS.
Okay. My PSA has gone from 1.15, 1.15 8 weeks ago to 1.69. I'm just wondering about the biopsy impact. This was after the biopsy. And do you think it made a difference getting the biopsy and driving my PSA, or is that just independent? Any experience about whether a biopsy would?
What's noise?
I'm sorry.
Hold on a minute. Let's just go back to MSKCC and Sylvester. If you're going to have this sample analyzed, just be aware that if you do it through MSKCC, they use their own proprietary genomic analysis. It's different from it's a different system, and it takes significantly longer than if you went to Foundation Medicine or Tempus or the Myriad product, MyRisk. Those are going to be a much faster turnaround for you. So if you want to check with MSKCC, fine, but decide where you want them to send it, and then have them send it out. And we talk about here FMI, Tempus, Caris, and we don't have a lot of experience yet with MyRisk. I mean, I'd love for Harrison to go back and comp us half a dozen MyRisk tests so that we can get guys to go out and send a test both to MyRisk and to somebody, one of the others, and we can see whether there's a difference in the results. Otherwise, we just have to wait until people choose MyRisk, and then we can see if we're getting good results. But we'd love to do some side-by-side testing. Harrison, it's good time to bring you in on this genomic sequencing. Are you there?
So, Rick, can I make a correction?
Just let Harrison respond,
It's not genomic.
Somatic.
Well, it's always been called genomic.
Genomic
It's
is
not
when
genetic.
you sequence your genome. Somatic is when you sequence the tumor.
Okay, I get it.
Harrison, are you there? Oh, don't hear Harrison. He may have dropped off.
Yeah, I think
Can I ask about the whether anybody believes the rise in my PSA can be at all related to the biopsy?
No, I don't. I don't, Jack.
Okay, so when you hit a lymph node, it doesn't disperse into the blood in any way and show up in the PSA?
It depends. How soon after you hit the lymph node did the PSA get into your bloodstream, and
It's a week later.
Yeah, I mean, it's probably gone by then.
Okay.
Oh,
Okay.
wait, I think I misunderstood something. I'm confused. So in the lung, so we're not talking about non-small cell lung pulmonary adenocarcinoma. We're talking about prostate cancer.
This is lymph node only, lit up, nowhere else in my body, not the parenchyma of the lung, just the lymph node. The subcarinal node lit up positive on the examen, but not PSMA. And they biopsied and they were able to determine that it was adenocarcinoma metastatic. But the other lymph nodes surrounding the subcarinal were negative. Okay.
Gotcha. Oh, I thought we were talking about a whole new cancer in
No,
the parenchyma lung. Sorry.
thank God. No. So the radiation oncologist that I was that I consulted, he said he can do SBRT. He said it's close to the esophagus, but and the bronchi, and there's a possibility if he does it, there'll be some inflammatory changes, and maybe I'll have difficulty swallowing to some degree. But he thinks it would be reversible. I said, gee, that's kind of scary. And then he said, however, before going ahead and spotting my lymph node, let's get a PSMA scan, and that's going to be repeated on the 17th of this month. No sooner, and that's only because I've been an atrial fib for 2 months, and I have a monitor I'm wearing. The stress of whatever it is, it brought it on. I had an ablation 10 years ago, and it came back since I've been dealing with this. So I'm taking a new medication called Multac and Eliquis. And does anybody have atrial fib in this group? Anybody being treated for it? I ask that only because combining this medication with androgen deprivation is very tricky.
I'm being treated for it.
Who?
It's Jeff Markey.
And you're being treated with what medication for atrial fib, if I can ask?
Coreg. C-O-R-E-G.
C-O-R.
That's the short name for it. Cardiovol, I think it is.
Okay. And have you had ADT in conjunction with that?
I had an AFib event about a month ago. And all the different things we take are a factor in it. I had a lot of skip beats just before the event itself. But the Coreg has almost completely stopped it. The Cardiovol, I take 3.25 milligrams every 8 hours, and the skip beats have seemed to go away as well. So there's lots of different treatments for AFib.
I'm aware of that.
Including the going in through your thigh and or maybe your wrist and ablating it if it's really a major problem.
I had that 10 years ago.
Okay.
It's come back. Okay.
Have they said any chance they could do it again to kill other areas that are causing it now?
Good question, and I'm going to pursue that with the guy in New York who did it the first time, because that way I can avoid the medication that could interfere with the ADT in the future.
Yeah, it doesn't interfere with my ADT at all.
Okay.
Not at all.
This medication,
but it may not be the right drug for you. I can't say that's the right drug for you. You have to speak to a cardiologist.
I understand. Now the they want me to start some ADT in conjunction with the SBRT, assuming the PSMA doesn't light up other areas of my body. I'm just wondering, I told him I'm not going to go for that right now. He said, no problem, we can do the SBRT, but it's recommended that you do start it before you do the SBRT. I said, well, look, I'm getting a PSMA scan. I can't start it before I get the PSMA scan. I would have to start it after the scan, because I'd like to see if it lights up PSMA for the future and also for what's really going on now, because in the event that this thing is spreading, I'd like to be a candidate for Pluvicto down the road. And we've never determined if I had any PSMA avidity. So he understood and he said, okay, well, let's go ahead and get the PSMA scan and then we'll take it from there. So that's on the 17th. I'm having a PSMA scan. I was debating whether to go up to New York or do it down here. I'm going to do it down here because I just don't want to keep jumping up to Sloan Kettering. And the other thing is I wanted to ask you guys about a friend of mine who's a GU guy who's a chairman of a department, lives lives down here part-time. He said, why don't you just fly to Germany? He said, get a couple of Pluvicto infusions, pay some money, and you can do it off the record, without FDA approval. And, that's a good chance. You only probably need 2 infusions. And I said, really? I said, I ran that by Belucich, and he said, forget about it. He said, it's not a cakewalk. And you guys have had it, and I've heard you talk about it. And nobody's told me it was or wasn't a cakewalk, but I just wonder what your thoughts about somebody doing it without having any other therapy and going to Munich 6 weeks apart, like several people I know have done. One in particular, Paul, who wrote a book called The Salamander's Tale. I don't know if you're familiar with it. Paul Friedman's a psychiatrist in Washington, and he did it years and years ago, and he's got no PSA left there. So I wonder your thoughts on that.
Well, I mean, I'm aware of at least a couple of guys that have gone for radionuclide lutetium treatment when they would not have been eligible here. One of them was earlier than you. It was almost like a primary treatment. It lasted for about 2.5 years, and now he's back in treatment again. The other guy just did the treatments in Turkey. By the way, it's cheaper to do it in Turkey now than it is in Germany. And he's a guy that has more advanced disease, but didn't want to go on ADT, and the jury's out. I don't know how he's going to do, but I could be happy to connect you to him.
If it hasn't been that long, there's no way of talking about durability. If it's
right. He can talk to you about the process. He cannot talk to you about how effective it's been.
Is there any long-term studies coming out of Germany or Turkey or Australia or where they've done actually follow-ups to see how long this stuff could potentially last with somebody who's had
I don't know about follow-ups, but there was just a study that was published by somebody this past week. I thought I put it in. Didn't I put it into the reminder about the safety of recurrent treatment?
No, I think what Jack is asking is what's the durability of this?
Any long-term studies on durability?
And unfortunately, it hasn't been around long enough.
Well, if it's been in Germany for like 3-4 years, they must have a clue. Maybe even longer than that. This Paul Friedman guy who wrote the book Salamander's Tale, he had it way before it was even approved, and he's had 6 infusions, and he went every 6 weeks to Germany, and he paid through the nose, and he's PSA 0 right now, and he's had it all over his body. I highly recommend the book. If anybody read it, The Salamander's Tale, it's really something. I mean, I highly recommend it. You can get it on for a couple of bucks. It's quite a few on Amazon, but terrific book. Anybody what are my options at this point? I'm so new to, let me hear from you guys. What would you do if you were in my shoes? You brain trust guys.
Well, Jack, you're not on hormone therapy now?
I've never been on hormone therapy. I had surgery 20 years ago, and I thought I escaped 15 years, 0, and reoccurrence 5 years ago. Oh, it's been 5 years.
I mean, that seems to me to be the most innocuous start. Yeah.
Try Orgovix.
Orgovix, yeah. Orgovix plus darolutamide if Belucich can do it for me. Yeah, I'll certainly ask him to do that once I get my PSMA scan and see what shows up. But even regardless, I know I'm going to have to go on it.
That's what I would do, Jack.
Yeah. I'm just worried about the atrial fib,
Right. But I mean, that is a problem. But we don't know what Orgovix does with atrial fib.
Yeah, well, I don't want to find out. But So that's it for me, guys, and whatever you can do to help me and any other feedback, I'd appreciate.
Can I just say one thing, inject right here? You're coming up on a PSMA PET scan. Just be aware that a fairly high percentage of people with prostate cancers that don't generate PSMA. So just because PSMA PET scan is negative doesn't mean there's nothing there.
Yeah, I know. I've had two other PSMA PET scans, but they were done at a level of 0.32 and 0.52, neither of which lit up. I'm up to 1.69 now, and by the time I have it done on March 16th, and that was like a couple of weeks ago, it could be even higher.
I had them all the way up to a PSA of I think around 7, and they were 4 of them. They were all negative, and so it's pretty clear I'm not generating any PSMA.
Interesting. I asked Belushi to see if they can send it out for staining. He said, let's see what the PSMA scan shows first, and then we'll talk about that. I said, okay. But
yeah, just to clarify, you did not have a stain sent out yet?
I did not what?
You did not have a stain done yet?
PSMA stain?
PSMA?
No, I did not. I was hoping I could do it. I asked him since last week if they can do that, and he said, let's not do anything till I get the PSMA scan on the 17th. Then, depending on whether or not it shows up, will help him determine whether or not that would be worthwhile doing.
If you do get a stain done, what effect does that have on treatments? And if it shows that you don't generate PSMA, then you
then it does. If it says if it's a negative stain and I have PSMA non-avidity, I'm in Herbst court, then I just I won't be a candidate ultimately for Pluvicto.
I have a pacemaker and I have AFib, and the pacemaker records everything. And once in a while, I'll have an 8 or 12-hour session of the AFib, but I'm on Eliquis for that and taking Firmagon.
I'm on Eliquis. I'm also on Multac, dronedarone.
That's the one that has the interaction.
Yeah, that's correct. And I won't take the amiodarone because of what it does to the thyroid, and I may end up with sotalol. I'd have to figure that out. A little tricky right now. So that's where I am, guys. That's what happens when you get to be my age. Everything falls apart.
All right.
Thank you.
Thank you, Jack. Can we go to Brad Smith?
Yes, thank you so much. I'm just absorbing so much information. It's incredible. I'll give you a real quick background, I hope. 20 years ago, a business partner who was a surgeon in Brea suggested I get PSA tests with my annual cholesterol test. So I had a lot of those results. In August of 18, during that test, I had a PSA of 9.25. Did a biopsy. The right was clear, the left was a Gleason of 4.3, with 4 or 6 cores, 80%. They recommended surgery right away. Well, being the person that I am, I started looking for other alternatives. I heard this brand new procedure called HIFU, and in LA there was UCLA and Cedars offering that procedure. So after the PET MRI in December of 2018, I had the HIFU. In August, my PSA was 0. And I thought, oh, there's the cure. I'm home free. Well, in November of 21, a PSA went to 10.14. went back to the practicing HIFU doctor, said, we'll get you in, and that was in March of 22 for a second HIFU. PSA dropped to 5.3, and where I'm at today, PSA has gone to 6.3. Before I met this group and the people in it, I had decided, 3 biopsies, 2 procedures, I'm done. I'm not going to play this anymore. But where I'm at today, because of the information here and the tremendous support I've gotten, I'm scheduled for a PSMA PET in 3 weeks. I have seen another oncologist who recommended insertion of the beads, and the hospital where the HIFU was done called and said, we've done a genetic analysis of your biopsy. We think you should go on Lupon, get radiation as soon as possible. So my big question is there a cure for what I'm dealing with here, or is this going to be a lifelong procedure? Am I doing the right thing? So those are my big questions for the day.
So, Brad, are you new?
Yes.
So, Rick, I don't know, do you want Brad to come back next week and we'll give him a full half hour for the newbie treatment?
Okay.
Yeah,
All right.
I mean, it's just easier for us, Brad. There's issues here. HIFU, local treatment, recurrence after local treatment. Let me just check a couple of things with you because I want to make sure this is the best group for you. Is there, you had the HIFU, and then after the HIFU, the disease came back, and have you done a second procedure, a second protocol with it going up yet or not?
The first HIFU brought the PSA to 0.
Yeah.
And then two years later, the second HIFU brought the PSA to 5.3.
Okay. Was the whole gland, did they treat the whole gland with HIFU, or was it focal?
It was local, the left side only.
Oh. And what about the second time?
Again, the left side only.
Oh. Yeah, I think that, and is there any evidence that have you had a PSMA test?
I'm scheduled for that in 2 weeks, thanks to the help from this group.
Okay, so have you listened to us before on the recording? Is that how you know us?
Yes.
Yeah. I'm tempted to say that you should start with Peter's group. And the reason for that is that there are a couple of guys in there who went through early focal treatment and the disease came back. And then, now that said, Julian, do you want to say something before? I mean, where should we send Brad, Julian? Are you with us? I see you there.
I'm still here.
No, you're there. No, here comes Julian.
I stepped away.
Okay.
Julian, did you hear what Brad has a situation similar to yours? He's had 2 lots of HIFU, and his disease is not going away. And we're wondering, should we bring him back to this group, or should we send him to Peter's group? How likely is it, do you think, that he's going to be facing that there are other alternatives before he starts on hormone therapy?
Well, if he's had HIFU, then it's recurrent. From my point of view, I would have him in this group.
All right, thank you. That's it. Come back to us next Monday, Brad. I'll be in the chair, and we'll examine the situation properly. We'll give you the due time at the beginning of the meeting. And are you signed up for our reminders?
No, but I will be.
Okay, so sign up, make sure you get a reminder, come on in and we'll talk to you about what the options are when focal treatment fails at the beginning. I'll see if I can get Dr. Mark. I'll ask Dr. Mark if he'll attend because he's a real expert. Mark Perlow is a real expert on this topic as well. So I'm gonna lean on Dr. Mark to attend next week so he can give you the benefit of his experience as well. Okay, and he lives in LA, by the way. So
Okay.
or he does now. He didn't at the time, but he does now. So make
Thank
sure.
you so much.
Yeah. Okay. Len, can we
Yeah.
hear from Mr. Boardman, the new
Well,
slim down, slim
hold
line?
on. But Rick, hold
Yeah.
on. I'd love to hear from Joe, but first we have to get to Tony Fig. We didn't hear from him. He's at the last one on my list here, and then we'll go to Joe.
Okay.
Hi,
So
everyone. I met with my radiologist on yesterday, and he had collaborated with Dr. Van prior to that. And I'll be starting pelvic bed radiation. They're going to do the full pelvic bed plus another area because I had extra prostatic extension. And I talked to him about doing a higher intensity for a shorter number of treatments, as was mentioned in the forum here a few times, and he was not in favor of it. He said that when you do that, there's more long-term side effects from colon issues, and also with a higher intensity, there's his studies that he's read have shown more uh, mutations of the cancer cells. So he was going to do 38 treatments with a 68 Guy level, and I didn't know whether that Guy level was really. It seemed I pretty sure I heard him right when he said 68, but I didn't know if that would be a correct level to be doing it at. So it's
I
a
think
full
that's a
pelvic
good
that
dose.
he's going to be doing.
Yeah. I mean, I agree with John. The dose is right, but if it were me, I would get pelvic, especially with your disease. I would be getting the whole pelvic girdle done. I mean, these docs that where they have guys who have high risk disease and mutations and goodness knows what, and they only radiate the pelvic bed in whatever areas they feel like it. We see them coming back. And the downside for doing the whole pelvic girdle, in my view, I mean, I had the whole pelvic girdle radiated, and I don't see the downside in it. And I've got after effects. Yeah, I got side effects. Yes, I got issues, but but my prostate cancer has been at less than 0.1 for the last 13 years. And I had Gleason 4+4, and it was outside the capsule. And I just don't get these docs who won't do it. Now, we are, I think, going to have a debate on this between Daniel Spratt and Mac Roach. They both said yes. I've got to make sure they understand what we want, that they're agreed on the debate and the format. But Tony, I would not do it. I would go get more opinions. I would not just do the pelvic bed. What did you say? Pelvic bed in specific areas?
Yeah, he showed me on the uh, PSMA scan, it was going to be an area where that would cover the extra prostatic extension. I think more lymph node areas, but I will send him a message on the portal and ask him about doing the entire pelvic girdle.
He can come back and he can say, well, we think it has more side effects. You can't argue with him, but I don't know. Ben Nathanson knows quite a bit about this because he went through the same thing. Is your microphone working, Ben?
I think it is now. I thought it
Yes.
was. Oh, okay. Unfortunately, now that I'm in the spotlight, I have nothing to add.
Well, when you say you have nothing to add, would you do? I mean, first of all, you had to make this decision about how wide the area should be, correct? On for salvage, it was something that you faced.
It was not even a question. He did the whole pelvic girdle, and he looked for nodes that he could focus on. I got a PSMA PET scan so that he could find, extra juicy targets. But no, I had the whole thing, and I would get the whole thing again. Sure.
Yeah. Anybody else had to face that decision? And
That's what I had, and I see Steve's talking about hips. I got bilateral hips. They didn't have any problem with it. I did 70 gray, and when we were setting it up, the Radung said to me, I'm going to do this in 35 treatments instead of 38, which they normally do. He said because they're doing the SBRT, and he said I don't see any difference between 35 and 38. You get your 70 gray. So he did 2 gray a treatment, and I guess it worked. Who knows? We'll find out. But the hips aren't a problem as far as I know.
Anybody on here
going to be doing the simulation at his location, and then he gave me the option of going to Pluvicto Cancer Center, which is about a 15-mile closer satellite location, but he said everything is controlled by his computer and how it's done. So he assured me I'd get excellent care there with the therapy.
Yeah, but Tony, that's not the issue. The issue is the area they're radiating. This is right. The $64,000 question. I mean, is there anybody on here who just that went back for salvage radiation or adjuvant, whatever you want to call it, and they only radiated the pelvic bed and then they had issues and it came back after that? Oh,
yeah,
that's
me.
There's Alan Moskowitz. Speak
Alan,
up, please,
yeah.
Mr.
Moskowitz. So I had surgery 10 years ago, basically almost this month, and I had to have salvage radiation in May of 2016. And I asked that question to my radiation oncologist. He said to me, look, he said, you didn't have anything outside the prostate bed, at least in terms of nothing found on an MRI, which is all they had back then. And he said, don't do the girdle. He says, sure, it might come back. He said, but the side effects could be really bad. And he said, if you get a lymph node that pops up that we missed doing the bed only, he says, you'll deal with it then. And I took his judgment. And unfortunately, it did come back. I don't think it ever went away after the radiation. And while one could say, well, would have been better to have that whole pelvic girdle irradiated. In my case, because I'm suffering already from radiation cystitis in the bladder, I'm glad I didn't have any more radiation. It would have been a disaster. God knows what would have been with radiation proctitis, etc. But I'm the anomaly, all right? I'll admit that only 5 to 15% of the people get this radiation cystitis with hemorrhagic bleeding, from what I know. And so for me, it was the right decision, and my cancer isn't so bad. It's been under control. I had a year of Lupron and Xtandi. I'm off that, and I'll have my first PSA test 3 months post-drug coming up in March. And I'll let you all know how that proceeded. But that was my experience and my decision, and I don't have any regrets.
Alan, did you have brachytherapy?
I'm sorry?
Did you have radiation therapy?
No, I had beam radiation, IMRT, IGRT.
Okay.
67 gray in 37 or 38 treatments.
Anyone else have a, by the way, I see a couple of guys arriving. This meeting is about to finish. Hate to tell you, but this meeting starts at 4 o'clock on the Tuesday sessions. Sorry, when I shouldn't say 4 o'clock. It starts at 3 o'clock Pacific on the Tuesday sessions, 6 o'clock Eastern on Tuesdays. The Monday session starts at 8 o'clock. Anybody else have anything they want to say to Tony Fig? I mean, for me, I would do the whole pelvic girdle. Ben would do the whole pelvic girdle. Norm would do the whole pelvic girdle. For some people, like Alan, maybe it wasn't right. Anybody else want to talk about whole pelvic girdle versus rabbit ears or whatever other pattern they want to do?
Yeah, I just had the bed done, and again, I had reoccurrence.
All right. Well, thank you very much for all of your input, and I'll look into that and maybe get another opinion.
Okay, Rick, do we have time for Joe, or should he come back next time?
I don't want to, Joe. We will never see him again if we make him come back next time. I know that. We won't
No,
see him.
I'll come back. I mean, I don't want to make it go long.
Yeah, once every 6 months we see you. We
I'll
got
come
you.
back. When's the next
We've
one?
got,
Next week? I mean, I forget.
yeah, next week,
Okay.
or you can have 10 minutes now, or you can come back next week. But we
I thought
really
you,
want to hear from you.
maybe I
We
misunderstood
really
that
do.
there's another meeting starting in the same room right now. Is that what you said?
No, it doesn't start for another 24 minutes.
Oh, I could go on for a few. Yeah.
What would you prefer to do,
Oh, I
Mr.
can start.
Professor?
I'll start now if people are interested. It's a, you know, if
Yeah.
you remember Monty Python, I'd say now you're in for something completely different. Because
Let's Joe. Let's just let everybody know that Joe's going to talk to us about his experience with psilocybin. If you're not interested in that, you're free to leave. If you are, then
Well,
hang in there.
I want to frame it, Joe. It's Len. That's too simple a way to frame it. What we've got to tell people is that Joe is a young guy who had stage 4
I was 50.
metastatic
I was
prostate.
50. I can give you the 10-second rundown.
Yeah, go
In
ahead,
20
Joe.
in 2015, I was 54 and had a PSA of 2. 2016, I was 55 and I went to 4. My doctor said, we got to do something. I went and the PA stuck her finger up my butt and went, oh, and it went downhill from there. And biopsy was 9 out of 12 with 7s, 8s, and a whole bunch of 9s, to quote him. But since there was no proof anything had moved and I was 55, I did the Da Vinci surgery day before Thanksgiving 2016. January of 2017, my first PSA test had gone down from 6 instead of to 0. It went down to 1.3, and then it was doubling every 3 weeks thereafter. So that was really bad. And I had maybe we can convince, Rick, that there are good GU-oncs in Denver, because one of them said, you just barely qualify. Oh, and then I went down to Arizona and got the carbon 11 scan, and they found mets in my hip and my lungs. And so the visceral mets and the one in my bone made me qualify for the early docetaxel, which I did in the spring of 17, 6 years ago right now. And I did the early docetaxel, followed by Lupron plus Abby ever since, in the last 6 friggin' years. And my PSA went to undetectable. And it sounds like a big success story, but I'm such a nutcase that after a while I got depressed I got depressed about the cancer, obviously, but then I got more depressed about and just weirded out and freaked out and upset that it wasn't coming back like it was supposed to. So count me among the weird, but every time I would get a point less than 0.01, I'd go, well, wait a minute, don't you people know what you're doing? I was supposed to come back by now. And so I had my problems with depression before cancer, but boy, did it that. And then the mental issues of the chemo and the Abby plus Lupron just really kicked in and drove me right into the ground. And so by November of last year, I'd worked myself into a fairly catatonic state in terms of depression, but I've been reading for years about the psilocybin treatment, and I'm not exactly
from my old college days in the 70s, what you'd call psilocybin naive. So I tracked down a guy in Colorado, and he helped me with what he would call a psilocybin ceremony, because he comes from kind of the spiritual side, not so much the medical side. And I got to tell you, it flipped my life from a 0 to a 1, from night to day, from non-functioning to functioning, to being pissed off when my thing came back undetectable, to glad now that I had my first one come back undetectable after I feel better. And in the meantime, I went and lost 26 pounds because I've been quit drinking Cokes and started walking every day and eating less. And so it feels like a bit of a weird psychic win here. So if anybody finds themselves trapped in that same kind of corner that I built for myself, that wait a minute, why am I not dead yet, which doesn't let you enjoy living, let me know, or think about this as an option. And it's unclear what do we call it, durability, or how long this is going to last for me, but I'm a few months out from early November, and I think even my wife would say I'm doing better. So that's the short version.
Joe, what can you tell us about the experience?
It's hard to put into words. I don't know if you guys know, but Colorado, just right in the time frame I was doing this, the guy I reached out to had to write me an email back saying, no, I can't do this. But then he privately connected with me on Signal, which is an encoded thing like Telegraph, and said, no, I can help you, but I could lose my license. And so I did it with him secretly. And Colorado's just passed a law in that same time frame that they're opening the door for all this. I'm not sure how it's going to go, because he voted against it because he thinks that it's going to be this ugly mesh of what he thinks is something very spiritual and big pharma in a clinical setting. But I have no strong opinions there. But for me, it was really hard to put into words. It was sort of like, to be crass, it was like a chemical electroconvulsive therapy for me, right? It was like a brain and heart and head reset, where I'd driven myself into a corner from the 6 years of Lupron and Abby, and wait a minute, why am I not dead yet, And then I've been doing follow-up counseling with him, but we haven't done the mushrooms again. It was 4 hours. I felt so bad the day I went in there that we actually own our grave sites in Boulder, right? My wife woke up years ago and said, we need to buy grave sites. So we went and did. And I was so bad that morning I went and sat on my grave, because I felt like I'd come to the end. And I went in to see him, and 4 hours later I come out and it feels like a whole second chance. So this is more about depression and, head problems than cancer, but certainly I got there with the cancer.
I believe I just heard in the news yesterday that psilocybin's been approved in Oregon for treatment of depression, refractory depression.
Colorado just legalized it for exactly this purpose, and frankly any other. It turns out the way the law was written, but it's if you go and look, the literature is undeniable, which is why I worked 2 years to find this guy, is the other thing. And so I probably kind of met my end when I knew I could see him. I probably timed my drama to match, but I looked for him for 2 years, and he was going out on a limb to help me, but it's not that way anymore in a lot of in several states. And, I hope it can help some people. It helped me.
So I've also heard from others, anecdotal stories that, like you say, it helped them enormously. It's a game changer. But they said they'd never do it again because apparently there were some harrowing aspects of the journey.
You face every fear you've ever didn't even know you had. Yeah.
Yep.
Right.
Okay.
But in in the old hippie days, we used to say set and setting were important, and boy, amen. So you need to trust the person, and there's an element to having enough that there's an ego losing moment or more, and and it's hard to describe.
Yeah.
But I mean, I'm not going to argue with the outcome, right? I thought it was impossible for me to lose 26 pounds, but all I had to do was quit drinking Cokes, go walk every day, and eat less, well, duh. But, and there's a book he turned me on to, if you guys really know all the freaky stuff, a guy named Gabor Mate. And he wrote a bestseller that's out right now about the real source of disease in the world. And his book's called The Myth of Normal. I'll drop a link in here real quick. I've given away like 6 of these books after I read it. To all my doctors first. It's an interesting book.
So, Joe, are you still on ADT?
Oh yeah, man, I don't want to die now. So yeah, I've been on. I mean, I would get so depressed, I'd quit taking the Abby for a month, and my doctor would go, that doesn't make any difference if you've been on it 5.5 years. You can quit for a month, and that ain't gonna change anything, and it didn't. But yeah, I've pretty much been on Lupron and abiraterone since 6 years ago now, when I finished the early chemo.
Well, maybe when you come in another time, we've talked about this before, but we'll have another discussion with you about intermittent, because we've got some guys, we got plenty of guys doing intermittent. So, and the other thing I just wanted everybody to know is that this man has climbed, is it 3 or 4 of the highest top 10
Oh yeah,
peaks on Lupron?
my son's a mountaineer, and he got us to go climb some big ass mountains. So we climbed all these big ones in Mexico, and then Aconcagua in South America, and Kilimanjaro. But that was, I'd given all that up. Like I thought, I'll never be able to do that again. Right now I'm kind of training for this summer. So it's a different Joe than you're used to, Rick.
Oh, I don't know. I like this. I like this new Joe. I'm looking. I think we have a blog entry on Mr. Boardman and his family, which I'm just looking up.
It was so much fun. The marketing department at the University of Colorado Health, the hospital in Denver, they made a marketing film about my terminal cancer, which they had a hard time selling to the director of marketing, but the lady did a great job on it. Now I live in like fear that somebody's going to find me, recognize me and go, "You're that guy that was supposed to be dead 3 years ago." Sorry.
Okay, I'm going to put one quick link in here. I'm putting one quick link in here, and I think we do have to stop, but we hope that Mr. Boardman will come back and join us again. Professor Boardman will come back and join us again, and we can talk more with him, because you can now understand why I was so pleased to see him again. And so here's everyone. Hold on, everyone. Here's the link, or if you just go to our website and search for Boardman, you'll find some stuff. You'll find some great stuff on him, and the link's in there. And I recommend you read it.
What about this internet? Yeah. All right. Well,
thank you, Joe. Thank you so much. Rick, should I stop the recording?
Yeah, I just want to say that maybe we can ask Dr. Jack and Dr. John to comment on this. If Joe's in next week, we'll bring it around to this, and we'll get some comments since we have 2 board licensed psychiatrists who think pretty broadly. We'd love to hear from both Jack and John next week, but we don't have time right now, I'm afraid. Sorry.
Okay, cool.
Okay, we gave them time to prep.
Yeah, we're giving you time. Dr. Jack and Dr. John, we're giving you time to do your homework before next week.
Don't need time. I would say positive things probably.
We love you.
Let's see what Jack says.
Look, here comes Kimmy. Here comes Kimmy, and we're still in the old meeting. But you're okay, Kim, because we stopped the recording. So we can let everybody go and stay in this room now. If we want, can we?